also a very nice number. Today I'll be giving a talk on behavioral underpinnings of hesitancy and implications for vaccine acceptance. The big questions that I'm going to be thinking about today is, what are the behavioral underpinnings of vaccine hesitancy? And particularly thinking about this in the context of the tools and approaches that marketing can use to unpack vaccine hesitancy and the implication that has for vaccine acceptance. We know from prior research that anti-vaxxers represent a small but vocal subset of the population. Depending on which study you look at, anti-vaxxers constitute roughly 5 to 10% of the population, depending on the population that's been studied. So of the 90 to 95% people who are pro-vaccine, nonetheless, they might experience some hesitancy. They might experience some uncertainty, some discomfort, a lack of confidence in vaccines. And I'm interested in asking why that might be the case, especially for people who are pro-vaccine. You know, why would we nonetheless have this sort of emotional quandary about getting vaccines for ourselves or for our children? And because I'm in marketing, I'm also interested in the service experience. So particularly how vaccine hesitancy impacts not only vaccine acceptance, but also the patient-provider relationship, perceptions of that service experience, and other downstream consequences that might also have an impact for health and well-being. So as Anisha mentioned, it's probably unusual to see a business faculty member speaking, to clinicians, medical practitioners, and providers. And my approach, and I wanted to give you some context, is that I am what's called a transformative consumer researcher. So maybe you've watched Mad Men and you've seen Don Draper, and you have this stereotype in your head of marketers as being focused on sales and profits, perhaps at the expense of well-being. And transformative consumer research aims to undo these perceptions. This is a broad movement within our mainstream marketing organization, the Association of Consumer Research, that really has 6 key pillars that I've identified here. To employ rigorous theory and methods, but to understand and appreciate sociocultural and situational contextual differences. We partner with consumers and their caretakers, and also various stakeholders, including public health agencies, governmental agencies, and nonprofits. So our goal is really to think about marketing in this holistic sense of improving consumer well-being, keeping in mind the context that consumers are navigating and operating in, the role of social ties, and the role of various agencies, be they public health agencies, other governmental groups, policymakers, and also potentially nonprofits. I am an experimental researcher, and so my bread and butter is using tools from social psychology and behavioral economics and using experiments to test for causality. So I am not a qualitative researcher so much. I don't do small group interviews and things like like some other scholars in the field do. I am primarily an experimentalist. So the team, I'm going to present a few different projects today. I'll talk about 3 different projects briefly that I have in progress, and also room for collaboration and some unanswered questions. My partners are a diverse international group of people that I've gathered together from faculty in marketing and management, including Paul Connell and Gary Sherman from here at Stony Brook University and the College of Business. I also work a lot with psychologists as well as practitioners, and one of my co-authors is a physician. She's actually a pediatrician, and she also now has a dual position with the Philadelphia Department of Public Health. So my collaborators within Stony Brook are Paul Connell and Gary Sherman, as I mentioned, and outside of SUNY, I work with Beth Fallon, Kristen Feemster, who is at the Philadelphia Department of Public Health, Wendy Boland, Beatrice Pereira, Amy Phil, Gabby Jigaboy, and Marta Casarati. Gabby and Marta are in Britain and Italy, respectively, so it's a very diverse international team, which poses some opportunities for cross-cultural data collection. So I'll just dive right in and tell you a little bit about a few projects that I'm working on. And this is just the big picture, one sentence summary. In the first project, I was really interested in a construct called psychological reactance, which is a person's propensity to restore their autonomy when they think that others are trying to impose their will on them. So one of the classic examples from the initial psychological reactance work is to ask, for instance, what happens when you tell a child they can't have candy or treats in the home. The child reacts, they experience this strong disagreement with what the parent is trying to tell them, and so they're more likely to seek out and eat large amounts of candy outside of the home. Psychological reactance is something that does impact quite a few Americans. And so we were interested in asking how psychological reactance might work in the context of vaccines. And what we found is that compared to people who are low in psychological reactance, people who are high in reactance, that is, people who react the most when they feel like their freedom or their autonomy is being taken away from them and that they are restricted, these people who are high in reactance place less priority on vaccinating. And this is driven predominantly by perceptions that communication between patients and providers have broken down. And so that communication is flawed. They don't necessarily trust their physician as much to give them advice. And so in some ways, it might be that even when physicians don't intend to be paternalistic or recommend strongly certain courses of actions, those who are high on psychological reactance might nonetheless experience implicitly even the subtle sense that they're being told what to do. And so as a result, they want to engage in the behavior that is not immediately being advocated for. In another paper, I looked at omission bias and moral culpability. Omission bias is a finding from the judgment and decision-making literature, and it measures or captures the tendency to consider harm from inaction preferable to equivalent harm from action. So that is people's belief that not acting or not taking action is better or preferable to actually taking action. So what does that mean in a vaccination context? Well, let's imagine that you're a parent and you're facing this choice to get a childhood immunization for your kid. And I remember experiencing this very strongly when we took our daughter, for her first round of vaccines. So if I vaccinate my child, she might have a negative reaction, like a fever. She might be crabby. She might, not sleep well. She might have all of these sort of negative immediate consequences from getting the vaccine. And the trade-off is that by not getting the vaccine, at 2 months, the most common immunization is the DTaP, which involves pertussis, which is particularly deadly for young kids. So, thinking about it, I can trade off the risk of my child having a fever or experiencing consequences from getting the vaccine to not getting my child vaccinated and having her catch whooping cough. So in that case, not acting is presumably a little bit more severe. Whooping cough can be deadly. But omission bias does look at, this tendency to prefer not taking action, even when the costs of acting and not acting are equivalent. And so what we looked at in this study is how omission bias might impact preferences for vaccination, and also the relationship between parents and providers. In this case, this was in the context of childhood immunizations. And what we found is that those who exhibit stronger omission bias have stronger negative responses to physicians' vaccination policy and lower trust in medical providers. So this effect particularly was driven by differences in perceived moral culpability, such that people who exhibited high levels of omission bias felt a heightened sense of moral culpability. That is, they experienced the stronger emotional reaction and attributed more causal blame, to themselves. When they considered taking action and their child had a negative vaccine side effect, such as a fever, compared to when they considered inaction. That is, their kid contracting a vaccine preventable disease. And so people who experienced or who had this tendency to consider inaction preferable to action also tended to associate a stronger sense of anticipated moral culpability with taking action versus not taking action. Okay, I know that's a little complicated, so I'm happy to elaborate more.
Yeah, can I ask you a question?
Sure.
So you said this was a review, or is this like you surveyed or you gave some kind of assessment of people around you?
Yeah, so we ran an experiment. We looked at, I think, 400, roughly 400, maybe just slightly less than that, parents in the United States. And we measured omission bias and perceived moral culpability, as well as their intention to vaccinate and their perceived trust in medical providers.
So I guess I was asking, how do you measure, for example, omission bias? Do you have like
yes, so there are standard measures from the literature. I am happy to dig up that site once I have my slides off the full screen. So there are standard measures. We looked at omission bias in 3 different contexts. We looked at it in a medical context, which we felt would be really relevant for this. So the tendency to prefer not taking action when faced with certain diseases, as opposed to taking action, visiting your doctor, getting a test, that sort of thing. We also looked at it in the financial domain, as well as in, I think, the domain of like homeowners insurance. So we looked at it in 3 different domains, basically looking again at this sort of preference for inaction. So in the financial domain, a preference for not reallocating your stock portfolio when new information comes up. In the homeowners domain, not switching insurance plans when it looks like, I think, the environmental conditions have changed. And what we found is that regardless of the domain that we measured in, the medical domain, the financial domain, or the insurance domain with risk to your home, it didn't matter. Just this general preference for inaction versus action really predicted the relationship that these people had with their medical providers, as well as their likelihood of accessing immunizations for their children. And so, you know, we've probably all had that experience where there are times where we sort of weigh, should I act, should I not act? And in some cases, it's so much easier not to act. And these measures really calculate sort of that general tendency of preferring not acting to acting.
Thank you. We'll probably get back in the discussion to this.
Yeah. I mean, I think it's incredibly interesting, and you know, it taps into, you know, I almost even wonder now if there are contextual differences. Everyone's just so depleted from COVID. And so maybe we sort of see this shift societally towards preferring not acting unless our environment really indicates that we do need to take action on something. Okay, this last project that's ongoing is directly related to COVID. And it looks at perceived vaccine scarcity. COVID vaccines are scarce. We all know that. I mean, I know that a lot of, you know, the medical practitioners, you know, in the hospital have gotten access, thankfully. But for the general, you know, population, vaccines are scarce. And there's also a lot of media coverage about the scarcity of the vaccine. And so we were interested in this study of looking at how all of this coverage about vaccine scarcity might increase vaccine acceptance. And so what we did is we experimentally manipulated, we had 400 students who first took this study. We're now running with a sample of 600 people in the general population. And what we did is we experimentally manipulated perceived vaccine scarcity. So either, you know, here's some information about the vaccine. The information is that, you know, the manipulation that contained information that the vaccine was scarce. We compared this to a control condition with no mention of, you know, the available levels and supply of vaccines in society. And we measured COVID-19 vaccine acceptance. And we found something really counterintuitive. And so if you think about the classic economic laws of supply and demand, when we find out that things are scarce, we want them more. So if we find out that a luxury product like a handbag is really scarce, oh my gosh, it seems like people want it and they're willing to pay so much more money for it. And this happens for all sorts of goods, not just luxury products. So we had expected that finding out that vaccines were scarce would actually increase vaccine acceptance. That is, maybe it's scarce because a lot of people want it and I can't access it. Or maybe, it's been scarce because of supply production issues, but that makes me want it all the more because it is this scarce resource. We found the reverse. We found that among those who perceive they're not likely to get a severe case of COVID, so the average college student who probably doesn't think that they're likely to get very sick, conditions of high scarcity decreased vaccine acceptance. Now, this was really interesting to us because even though college students might objectively be less likely to get a severe case of COVID, they nonetheless can be considered in many instances super spreaders, right? People who are responsible for the spread of COVID-19 throughout the population. And so if the average college student doesn't perceive that getting the vaccine is important to them and they don't want to get it, then that really is an important thing that we need to consider for society. We need to consider how to undo the negative effects of this messaging. And so we have a study that's running right now where we look at what's happening for people who believe they're likely to get a severe case. And so we know, like I said, that college students perceive their low vulnerability, even though they are responsible for substantial spread of COVID. So what happens when we look at people who are medically vulnerable? Maybe they have chronic conditions that pose additional risks. We would expect that this effect would either attenuate or maybe even reverse completely. And so scarcity might prompt people who haven't yet had the vaccine, but who are highly vulnerable to get the vaccine, which would be a good thing. We want these people to get the vaccine. We're also interested in understanding the underlying reason for the effect. Maybe it's something altruistic where college students think, you know what, I'm not so likely to get sick from the disease. If vaccines are scarce, maybe I want people who are more vulnerable than me to have access to the vaccine. That would be an incredibly altruistic motive, but it is one of many inferences that college students could be making. And so we want to disentangle the reasons why college students who tend to be a low vulnerability group might have decreased vaccine acceptance when they see information about the vaccine being scarce. So this is work in progress, but I'm very curious to hear your thoughts and your perceptions as well.
Thank you, Stacey. Okay.
I just have two quick things. So I'm interested in studying the behavioral underpinnings of vaccine acceptance, particularly as it relates to the perceptions of consumers, patients, vaccine candidates, and service providers, particularly as it relates to reaching vulnerable consumers who are traditionally modified, and also in thinking about interventions. And here's just some areas for collaboration. I work currently with practitioners, MDs, people in public health. I can always expand that, and I'd love to do so. There are a number of other disciplines as well. And I know that vaccine acceptance and understanding, ways of mitigating the spread of COVID are important. And so if there's room to form an interdisciplinary think tank on the topic to respond to grant opportunities, I would also welcome that. So I hope I'm within my time, and I've